We in Geriatrics department at Rahul Hospital provide comprehensive care to elderly people over the age of 65. That spans across, you have your routine physical illnesses like lifestyle diseases like hypertension, diabetes, dyslipidemia, cholesterol disorders, and you also have psychological or mental disorders like depression, dementia, and dementia and its various variants that you come across normally. We associate with multiple departments, and most of these patients have a multitude of drugs for their routine diseases like hypertension, diabetes, and dyslipidemia, plus disorders like thyroid disorders, mobility disorders, and then also comes in the picture of mental disorders or psychological disorders like dementias, various types of dementias, depression. That's quite common in the elderly people. And also with elderly people, you also have mobility disorders. They find it difficult to be mobilized. They have movement disorders like Parkinson's disease that is quite debilitating to the patient. And we try and we associate with multiple departments and bring across these things onto a single frame and try and reduce the medication load and provide as comprehensive and as efficacious treatment as possible for these conditions in the best possible manner with the least side effects. Because the drug side effects in itself can produce a significant burden on the functional status of the patient, on the mobility of the patient, on the mood of the patient, and that can affect the overall quality of life. So it is our conscious effort to try and reduce the medication load and to eventually result in a better functional status and a better quality of life. One of the most commonest mobility disorders that you see in the elderly is Parkinson's disease. It is one of the most commonest mobility disorders. It's associated with slowness of the patient. Patient becomes more and more rigid, they become slow. It starts off with very subtle things like their gait, the speed of walking becomes quite slow. They start fumbling while they're walking, they take very short steps, their handwriting becomes smaller, their facial expressions reduce. When they walk, their arm swing is less. So these are the initial symptoms that you see in Parkinson's, but as the disease progresses, it gets to a more magnanimous picture, resulting in severe rigidity, extremely difficult to walk, and these short fumbling steps can eventually result in a fall. A fall for an elderly person is quite catastrophic because it can be just a normal fall, can result in a fracture. The fracture would result in the patient being bedridden in a hospital post a surgery for X number of days, following which the patient could have problems like a bed sore, pneumonia in the chest, what we call an aspiration pneumonia, and that can only be the start of a vicious cycle of diseases. This can lead one after the other. A simple fall can result in a normally walking, talking patient to being a bedridden patient with multiple tubes for feeding, big bed sores, recurrent chest infections. So it is quite important for us to make sure that falls are prevented as much as possible. And the most commonest causes for this is Parkinson's. It is quite important to diagnose this quite early so that we can start treatment early for patients. And with medications, a big amount of these symptoms can be reduced quite significantly. Patients' quality of life can be improved because their walking improves, their social interactions improve, their mood improves, and further complications are reduced. And we initiate treatment for that with medications that are apt for the situation. We assess how the patient responds to the medications, and based on which we increase or reduce the medication dosage and discharge the patient with a very frequent follow-up of at least 3 months to see how the patient is doing with the medications. Because these medications, if gone on a higher dose, can have certain side effects that we want to be aware of. The patient is developing these side effects, and if they are, we try and reduce the medication load and titrate it accordingly as to what is apt for the patient. Most of the elderly people, patients, when they come with a disease, it can be as minor as something like a dehydration, constipation, any infection. Something that might seem very routine for normal people can actually make an elderly patient bedridden. But that is what we call deconditioning. What happens is that over a period of time, as little as 5 to 7 days, patient can lose around 1 kilo of muscle mass. It's quite debilitating because that itself will result in a difficulty in walking. Patient who was walking normally, speaking normally, doing things normally, had a routine infection, a routine urinary infection, or a dehydration, or a constipation, came into hospital, and these things get treated. The infection gets treated, the dehydration gets treated, but the patient is never back on his toes. He continues to be bedridden because being in bed for a very few number of days results in loss of muscle mass, making him to be bed bound. That has a very high risk for further issues like bed sores and aspiration pneumonia. So it is very important that he is put back on his toes as early as possible. So when we receive a patient, an elderly gentleman, our most important thing is that we try and maintain the functional status and improve the functional status as much as possible. We start off with an assessment on what the patient can do, what is his baseline, whether he is able to sit up in bed independently, whether he is able to stand up independently, whether he is able to walk independently. And we assess what is his baseline functional status and what is the disability that is impeding him from progressing any further. And we try working on that. We have regular physiotherapy sessions to make sure that these patients progress from being a bedridden patient to be able to sit on the edge of the bed, to be able to stand with support, to be able to walk with or without support. And you have various devices for it. You have walkers, you have frames, with which these being assistive devices improve the functional status of the patient, help in being the patient more mobile. And the physiotherapists continue to work with us, in tandem with us, to make sure that maximum functional gain is possible while the patient is in hospital. And we try and make sure that the patient does not leave the hospital in a worse functional state as to compare to what he was when he came in. Alzheimer's dementia is one of the most commonest dementia subtypes. Dementia is forgetfulness in layman's terms, and dementia itself has got various subsets. There are various types of dementia, and Alzheimer's dementia is one of the commonest manifestations of dementia. Patients tend to forget what happened, and it is something that is very subtle, that is something very slow, very benign, that often family miss the onset of disease. They might feel that forgetting where your keys are, forgetting certain names, forgetting certain places is quite normal for aging. They have that misconception that it is quite normal to forget with aging. So they tend to neglect these things. And over a period of time that can take years together, they slowly tend to forget what happened in the recent past. You will have a patient with you who did not remember what he had for breakfast, but he would remember what happened 15 years back, because it's his recent memory that is affected. Things of the past is well entrained in his brain, and he does not forget these things. He will forget someone he met 5 minutes back, but he would not forget his childhood friends, the names. Gradually, this memory deficit grows on. Over a period of time, he tends to forget his family members, forgets where he lives, forgets what his name is. He does not know, when you give him food, he does not know what you do with the food, how do you eat it, that's the eventual state of dementia. But it starts off with a very subtle manifestation, and it's very important for a geriatrician to assess the patient with certain, we have questionnaires called mini mental status examination. It's a 30-point questionnaire which we ask the patient, and based on that we are able to find out if the patient has an early onset dementia or a very early stage dementia, so that we can start intervening quite early. If it's a very mild dementia, we can try and have lifestyle modifications. We can assess for other comorbid illnesses that may be contributing to it. There are certain diseases like hypothyroidism, B12 deficiency that can actually cause a transient dementia state. So we try and assess for these things, make sure that these things are not there, and once we establish the diagnosis of Alzheimer's, we start treating accordingly with medications, with supplements, with physiotherapy, with other